Migraine management is usually considered in two big parts. The first part is lifestyle advice. So one advises a patient to have regular sleep, regular meals, regular exercise, regularity of things. One then talks about treatments. And in the treatments, there are two broad concepts at the moment: acute treatment and preventive treatment. The evolution of acute treatment has been the evolution from relatively non-specific things that are useful in pain generally, aspirin, acetaminophen, non-steroidals like naproxen and ibuprofen, through to specific treatments, the so-called triptans, serotonin 5-HT1B, 1D receptor agonists, that were developed in the late 1980s and then first marketed in the 1990s. So they're certainly effective acute therapies for migraine. What we're seeing at the moment is a further evolution in that. As we've gotten away from the idea that you have to constrict blood vessels, which turns out to be wrong, as it turns out that all you have to do is turn off these nerve pathways, that new medicines are being developed. And what we're seeing is that now we've seen phase 3 studies for two classes: the 5-HT1F receptor agonist, the ditan, specifically lasmiditan, which turns off trigeminal pathways and doesn't have a vessel effect and is clearly effective in the acute treatment of migraine. And another pathway, another group of treatments, the GPANs, calcitonin gene-related peptides, CGRP, small molecule receptor antagonists that have no vasoconstrictor effect, and two of them, rimegepant and ubrogepant, are both effective as acute treatments of migraine. So we're moving from very non-specific work in all sorts of pains to medicines that are designed for migraine, where we understand the pathways and they're effective and increasingly much better tolerated. We haven't done prevention yet, we're going to do that next. On the preventive side, what we've had for forever, certainly as long as I've been practicing, is a bit of a ragtag collection of things taken from other areas. So from blood pressure, propranolol, for example, the beta blocker, or candesartan, the angiotensin receptor blocker, both effective blood pressure medicines that work in migraine, and we've taken them into migraine. We've got from the epilepsy class, topiramate, for example, which is an anti-epileptic and is effective in migraine, and we've taken it into migraine. We have amitriptyline from the tricyclic class, which is an antidepressant. It's effective in migraine, and we've taken it into migraine. What we're about to see, what we've seen actually, is the evolution from that, taking things from other places and having that baggage and side effect problems, to specific migraine preventives. So for the first time, we have a class of specific migraine preventives, the CGRP, calcitonin gene-related peptide pathway monoclonal antibodies, which are effective in prevention. As we've seen these developments in prevention and acute therapies, the next level of thinking about this is you might say a hybrid, or what I think of as a sort of quantum level of thinking. So we know that CGRP pathway blockade from the monoclonal antibodies, and now from a new medicine called atogepant in phase 2, which is a small molecule receptor antagonist, that pathway can be used as preventive. And we know from the acute therapy studies with GPANs, that from rimegepant and ubrogepant, you can be used acutely. So all of us, what we suddenly come to is a pathway, the CGRP pathway, that works for both acute and preventive therapy. This is really going to change the conversation and understanding about treatment, because no longer is it sensible to say that you can just be an acute therapy or a preventive. That's clearly not correct. And how we leverage that going forward, and how that changes the conversation clinically, is going to be quite exciting in the next short period.